Hello, everyone. This is Chadi Alraies coming to you from Riyadh Structural Heart 2026. I'm really privileged to be with Dr. Gilbert Tang to talk about a new innovation as well as indication for tricuspid intervention. Dr. Tang, thanks for being with us.
Yeah, great to be back to Riyadh.
Yeah,
So as
thank you.
usual.
Thanks again for being here.
Yes,
Hopefully, the trip was good.
yes,
Great.
very smooth. Thank
Great.
you.
So you do all kind of big spectrum of intervention for structural, but given your expertise, we're going to dive in more to tricuspid. Tricuspid kind of evolving; it's getting more attention lately, but screening and patient selection is very important. Can you elaborate more on that?
Yes, absolutely. So I think first of all, tricuspid regurgitation is undertreated disease because it used to be called a forgotten valve. In the structural world, it's less forgotten, but I can tell you that a lot of people have not been able to image well on the tricuspid valve because it's just never been taught. And the first gateway to make the diagnosis is transthoracic echo. And it's actually not that difficult because, as you know, the tricuspid valve and the right heart is actually closer to the sternum and the chest. So actually seeing it is not that difficult, but to be able to get the correct views, and the sonographers need to be trained for that. So that's number one. Number two is that traditionally surgery has been considered high risk because these patients are often end stage. What I mean by that is that because of the TR, they have renal dysfunction, they have liver dysfunction, and so with surgery, when you have two organ dysfunction plus the cardiac dysfunction, the surgical risk is quite high, not just in terms of mortality, even though it's better, but it's actually the morbidity. They stay longer in the hospital, they struggle afterwards. And so it's very refreshing to see over the last decade now mature enough to have commercially available platforms through percutaneous means to repair or replace these valves. So I think it's very important for the global cardiovascular community to actually get trained to make the diagnosis, number one, and number two, to have a timely referral, because even though we have transcatheter options to treat these patients, if they're too advanced stage, they actually will not benefit.
Right, especially you are treating more symptoms and kind of lifestyle. So when is the right time to treat, and what is the perfect patient to be treated?
Great question. So first, we want to make sure they do have symptoms and the tricuspid regurgitation is severe. Now, as we know, the tricuspid regurgitation, the TL can be dynamic. So we need to make sure they're already on optimal guideline medical therapy for at least a month or so and see. If they remain symptomatic and the TR is severe, then they should be referred for treatment. I think that's very important. Not necessarily even to go ahead with a procedure per se, but actually get into the system so that they get better care. What we found is that once they get into the system of a heart team at a referral institution, they get better management because they get closer surveillance in partnership
Right,
with the primary cardiologist or the primary physician.
and attention, right, because they're seeing more often. Yeah,
Absolutely. And
yeah.
that's what we saw in the trials.
So, from your experience as a surgeon, uh, do you think now we have enough platform and devices available to treat transcutaneously, or there is a certain cohort of patients you still do surgery on?
Great point. So the ones that we still do surgery are, number one, the ones anatomically not ideal or suitable for transcatheter option, but they are still a surgical candidate. Two is the patient with multi-valve disease. So for example, if they're mitral and tricuspid disease, rather than staging transcatheter approaches, if the patient's a surgical candidate, they should have surgery for both. And more importantly, if they also have concomitant atrial fibrillation. As we know, that atrial fibrillation is a big factor in patients with not just mitral disease, but also tricuspid regurgitation. We now make that awareness. And these patients, even though if we fix the valvular disease, they still don't feel as good until we fixed actually the atrial fibrillation. So I think it's very important to take that into context that, if the patient's a surgical candidate, they should get their concomitant MACE procedure, AFib ablation at the same time as the surgical repair as well. Now, having said that, if they're not a surgical candidate, we still need to take care of the AFib. So we often work with our electrophysiologist to see if we fix one versus the other, and the staging and the sequence. The timing is critical here.
Absolutely. Well, Dr. Tang, again, thanks for giving us a great overview coming from structural surgeon from the US on what we have and how to select patient tricuspid valve. Watch the videos and others on the YouTube channel. This is Chadi Alraies coming to you from Riyadh Structural Heart 2026 in Riyadh through Tang. Thanks again.
My pleasure.